आज का हमारा टॉपिक है ब्लीडिंग डिसऑर्डर्स। इसमें आज हम करेंगे हेमोरेजिक डायलिसिस। बिस्मिल्लाहिर्रहमानिर्रहीम। Bleeding disorders or excessive bleeding can result from number one, increased fragility of vessels, defect in the vessels or vessel wall. Second thing is the platelet deficiency or dysfunction. कि platelet deficiency हो या अगर वो उनका नंबर नॉर्मल हो तो उनका फंक्शन जो है वो कम हो. Third thing is the coagulation derangement, either alone or in combination. The major thing is here that how to evaluate the different aspects of hemostasis. The first thing is prothrombin time or PT. It is done for the assessment of extrinsic and common coagulation pathways. The prolonged PT is either due to the deficiency or dysfunction of factor 5, 7, 9, prothrombin or fibrinogen. As you know, the fibrinogen is factor 1 and prothrombin is factor 2. So, the second thing is partial thromboplastin time, PTT. And it is performed to see the intrinsic and common pathway assessment. Prolonged PT is due to the deficiency or dysfunction of factor 5, 8, 9, 10, 11 or 12, prothrombin or fibrinogen. Third thing is platelet count. High count of platelets may be due to the proliferative diseases as in essential thrombocythemia. Platelets. This one is a major part of coagulation system. Coagulation system. These are small 1 to 4 micrometer in diameter. These are discoid, non-nucleated structures containing red to purple granules. The normal count of platelets ranges from 1,50,000 to up to 4 lakhs per microliter, and the lifespan of platelets is 7 to 10 days. Primary hemostasis. The function of platelets, initially platelet plug formation at the site of endothelial injury or injury to the endothelium. This one is the initial step, the platelet plug formation. This is followed by platelet adhesion. Adherence of platelets to the collagen in the endothelium by the help of receptors on the platelet surface, glycoproteins Gp1a2a. These are integrants. The adhesions to the platelet vessel's wall, it is further stabilized by one Willebrand factor. This one is an adhesion glycoprotein and the platelet receptors Gp1v9 complex. After adhesion, there is activation of the platelets and they releases the 3 types of granules from their cytoplasm. Number 1, dense granules, alpha granules and lysosomal vesicles. And the products from these granules which are released are ADP, ATP, calcium, serotonin, platelet, factor 4, factor 5, factor 8, thrombospondin, platelet-derived growth factors, non-Willebrand factors, fibronectin, fibrinogen, plasminogen activator inhibitor 1 and the thromboxane A2. These all are the very important mediators. Platelet aggregation after release is mediated by fibrinogen through the glycoprotein receptors on platelet Gp2b and 3a. The first class of diseases is number 1 is the vessel wall abnormalities. Majority of major infections like meningococcemia, septicemia, infective endocarditis, these all infections can lead to bleeding disorders. The microbial damage to the microvasculature and DIC. Drug reaction by deposition of drug-induced immune complexes in the vessel wall causing hypersensitivity, vasculitis, and bleeding. Scurvy, vitamin C deficiency disease, and Ehlers Danlos syndrome, both causing defect in the collagen and causing weakness of the vessel wall. Then hereditary hemorrhagic telangiectasias, perivascular amyloidosis, these are vessel wall abnormalities. Reduced platelet count or thrombocytopenia. Reduced platelet count below 1 lakh per microliter is generally considered as thrombocytopenia. Thrombocytopenia is an important cause of generalized bleeding. Bleeding associated with thrombocytopenia is associated with normal PT and PTT, prothrombin time and partial thromboplastin time. Decreased production. There is selective impairment of platelet production by drugs or alcohol or prolonged use of thiazide diuretics, cytotoxic drugs, or infections like measles, HIV. Nutritional deficiencies may cause decreased production like vitamin B12 deficiency, folate deficiency in megaloblastic leukemia. Bone marrow failure due to any cause causing aplastic anemia and decreased production of blood elements including thrombocytes. Bone marrow replacement by the leukemia, malignancy, disseminated cancers, and granulomatous diseases, or ineffective erythropoiesis as in myelodysplastic syndrome, leading to decreased production of platelets. Now, the decreased survival of platelets. They are produced but cannot survive. Number one, the immunological destruction, which may be primary autoimmune, and the disease is chronic immune thrombocytopenic purpura, acute immune thrombocytopenic purpura. Secondary autoimmune, secondary to the SLE, systemic lupus erythematosus disease, B-cell lymphoid neoplasm. Alloimmune causes are post-transfusion and neonatal. Drug-associated quinidine, heparin, sulfa compounds, all these drugs can decrease the survival of platelets. Infections like HIV, infectious mononucleosis, dengue fever, these infections are also affecting the platelet survival. Non-immunological destruction of platelets mediated in the DIC, disseminated intravascular coagulation, thrombotic microangiopathies, and giant hemangiomas. Then sequestration in hypersplenism and dilution resulting from multiple transfusions. Chronic immune thrombocytopenic purpura, an immune-mediated condition. It is idiopathic or immune thrombocytopenic purpura, and it is characterized by autoantibodies-mediated destruction of platelets and normal or increased megakaryocytes in the bone marrow. Pathogenesis of disease. The autoantibodies, these are directed against platelet membrane glycoprotein 2B, 3A, or 1B9. In majority of cases, these autoantibodies are immunoglobulin G class. As you know that immunoglobulins all are produced by B cells, plasma cells, derivatives of B cells. These anti-platelet antibodies, they act as opsonins and that are recognized by the immunoglobulin Fc receptors, which are expressed on phagocytes or macrophages and causing the destruction of platelets. In some instances, these antibodies may also bind to the megakaryocytes and causing the decreased production of platelets. Morphology: spleen is normal in size, normal or mildly enlarged spleen, prominent Malpighian follicles. Microscopic features: there is congestion of sinusoids and enlargement of splenic follicles, often with prominent reactive germinal centers, usually mild myeloid metaplasia or extramedullary hematopoiesis due to megakaryocytes. There is variable plasma cells in the marginal zone and variable macrophages in the red bulb of spleen. Steroid treatment diminishes the prominence of follicles and there is rarely periarterial fibrosis. Clinical features of chronic ITP. Most commonly, the adult female is affected under the 40 years of age. The disease is insidious in onset and female to male ratio is 3:1. And this disease is characterized by bleeding into the skin and mucosal surfaces in the form of petechiae or pinpoint hemorrhages, especially on the dependent areas, and these petechiae may progress to ecchymosis, easy bruising, nosebleed, bleeding from gums, soft tissue hemorrhages following minor trauma. There may be melena, hematuria, or excessive menstrual flow, and rarely subarachnoid hemorrhage and intracerebral hemorrhages may occur, and these could be fatal. The laboratory diagnose: how to diagnose. The blood picture show low platelet count and platelets are larger in size than normal. Bone marrow aspiration reveals elevated megakaryocyte. PT is normal and PTT is also normal. Third entity is the bleeding disorders due to defective platelet functions. The number of platelet is normal, but function of platelet is reduced. This could be inherited and acquired. Disorders are causing due to the qualitative defects in the platelet functions. Inherited defects are defects of adhesion in Bernard-Solier syndrome, defects in platelet aggregation in Glanzmann, thromboasthenia, disordered platelet secretion in storage pool disorders. The acquired defects are resulting from prolonged use of non-steroidal anti-inflammatory drugs like aspirin. Aspirin, a strong inhibitor of enzyme cyclooxygenase, which is necessarily required for the production of or synthesis of thromboxane A2 and prostaglandins. And both these mediators are used for platelet aggregation, platelet functions. Then acquired defect uremia. Uremia inhibit all the functions of platelets. Aggregation, platelet adhesion, platelet secretion, all functions are inhibited in uremia. The another entity is the hemorrhagic diathesis related to the abnormalities in clotting factors. Deficiency of clotting factors, these could be inherited or acquired, causing bleeding diathesis. The manifestation of isolated population deficiencies are from large post-traumatic ecchymosis or hematoma, or prolonged bleeding after a laceration or any form of surgical procedure, to the bleeding from GIT, urinary tract, to hemarthrosis, bleeding into the joints, into weight-bearing joints. The hereditary deficiencies are usually affecting single clotting factors. These are the factor VIII causing hemophilia A, factor IX causing hemophilia B, and the factor von Willebrand factor, which is causing von Willebrand disease. Acquired deficiencies usually involve multiple coagulation factors. The major cause is a vitamin K deficiency as the factor 2, factor 7, factor 9, factor 10 and protein C, which is factor 5. The deficiencies of these factors are actually due to the deficiency of vitamin K. All these are dependent on vitamin K. So the deficiency of vitamin K causing deficiency of all these factors. The DIC and the multiple factors are consumed during the disease becomes deficiency of factors. Now the hemophilia A, the factor VIII deficiency. Factor VIII deficiency, it is the most common congenital bleeding disorder that is inherited as an X-linked recessive trait, and it is characterized by mild to moderate to severe bleeding episodes. Factor VIII is also known as anti-hemophilic factor, so the disease that's why termed as hemophilia. Epidemiology of the disease is this almost exclusively affects the males, 1 in every 10,000 births or 1 in every 5,000 male births. Rarely affects the females and the female carriers are unaffected. Clinical features. Bleeding into the muscles, these are general factors, beta. Bleeding into the muscles, into the soft tissues, into the joints, bleeding from the gastrointestinal or genitourinary tract in the form of either melena or hematuria, easy bruising, excessive bleeding after surgery, trauma, dental procedures or circumcision, epistaxis, wound healing, intracranial hemorrhages, scalp hematoma. Repetitive hematoma may cause development of pseudotumors, menorrhagia, but the petechins are absent here. Pathophysiology, factor VIII, it is a plasma protein produced in the liver and by the reticuloendothelial system. It circulates mainly bound to the von Willebrand factor protein, and it functions as a cofactor along with the activated factor 9 to activate the factor 10, which in turn with its cofactor factor 5A activates thrombin, and the deficiency of the factor causing deficient clotting mechanisms. Etiology inherited as an X-linked recessive trait, 30% are due to the spontaneous mutations. The gene for the factor VIII, it is a large gene which is located on the fragile region of X chromosome. Most common mutation involves inversion of the introns 22. Less common mutations are missense mutation, large deletions, small point mutations, and insertions and deletions. The disease is classified into mild, moderate, and severe condition or disease. Mild is less common, occurs in 30 to 40%, and typically present with bleeding after surgery or trauma. In moderate disease, 2 to 5% activity of the factor, it occurs in 10% and present with bleeding after surgery or trauma, and less commonly with spontaneous bleeding. In severe cases, the factor activity is less than 1%, so occur in the 50% cases and present with spontaneous bleeding into the joints, muscles, and with life-threatening hemorrhages also. Laboratory findings here, the platelet count is normal, PT is normal, bleeding time is normal, but PTT is increased. The candidates for genetic testing include the patient who have diagnosis of hemophilia A or B, and the at-risk women who are related to an affected man who has a known mutation, or female carriers of hemophilia A or B for prenatal diagnosis. The cord blood sampling for the measurement of factor VIII activity in male fetus of non-carrier. Chronic complications of disease, musculoskeletal problems, chronic synovitis, arthropathy, fractures, contractures. Now the factor IX deficiency or hemophilia B. Factor IX deficiency, it is the second most common congenital bleeding disorder and is inherited as an X-linked recessive trait, and it is characterized by mild to moderate or severe bleeding episodes. Factor IX is also known as Christmas factor, so the disease is also termed as Christmas disease. Epidemiology, one is affected in 30,000 male births. Almost exclusively males are affected, rarely females are affected, and the female carriers are unaffected. Etiology, factor IX deficiency is inherited as an autosomal recessive X-linked recessive trait, but 30% of cases are due to the spontaneous mutations, and the genes again located on a fragile region of X chromosome. Bleeding into the muscles, soft tissues, joints, gastrointestinal, genitourinary tract, easy bruising, excessive bleeding after surgery, trauma, dental procedures, circumcision, epistaxis, poor wound healing, intracranial hemorrhages, scalp hematoma, menorrhagia. Pathophysiology, factor IX, actually it is a vitamin K dependent serine protease used in liver. It circulates in the plasma in its inactive form, and it is activated by factor VIII and catalyzes the conversion of factor IX to IXA. It can also be activated directly by the tissue factor. Factor VIIa complex in the extrinsic pathway. So its biological half-life is 18 to 24 hours. Classification of the disease into mild, moderate, and severe classes. Mild disease present with bleeding after surgery or trauma. In moderate disease, it present with bleeding after surgery or trauma and less commonly spontaneous. In severe cases, it present with spontaneous bleeding into joints, muscles, and as well as life-threatening hemorrhages. Laboratory findings, there is prolonged PT, normal PT and bleeding time, and the measurement of both factor VIII and IX activity by functional plasma clot-based assay or chromogranule substrate-based assay. Now the von Willebrand factor. Von Willebrand factor or von Willebrand disease. Most common hereditary bleeding disorders. Affecting 1 to 2% of the population. There is no gender preference, and due to the quantity